My name is Yuki Chihara from Tokyo Women's Medical University. So please let's get started this session. Each presenter has a 3 minutes presentation and 1 minute discussion. So the first presenter is Yuan Cho. Please get started.
Good morning, everyone. My name is Yuan Q, and I'm a cardiac surgery resident at the University of Ottawa Heart Institute. Thank you for the opportunity to present our research, outcomes following coronary artery bypass grafting with multiple arterial grafting by pump status in men and women. We have no disclosures. Evidence has shown that multiple arterial grafting is associated with improved survival and a lower incidence of long-term adverse cardiac events. Off-pump coronary artery bypass grafting has been proposed to potentially mitigate complications related to cardiopulmonary bypass. However, concerns with decreased patency and less complete revascularization exist in these cases. It is also unclear whether outcomes following multiple arterial grafting by pump status affect outcomes and whether they are different between males and females. Therefore, our primary objective was to evaluate in patients undergoing CABG to determine all-cause survival after multiple arterial grafting, depending on pump status in both men and women, as well as to determine whether on or off-pump CABG using MEG impacted major adverse cardiac and cerebrovascular events for males and females. We conducted a retrospective provincial population-based cohort study using data analyzed at the Institutes for Clinical Evaluative Sciences from October 2008 to September 2019. A total of 19,198 patients who underwent isolated CABG with multiple arterial grafting were included, and of these, 2,989 were women, 16,209 were men. Propensity score, Cox proportional hazards regression methods were used and balanced patients by pump status stratified by patient sex. The primary outcome we investigated was all-cause mortality, and secondary outcomes were MACE. As you can see here, after overlap weighting, the propensity score distributions were very similar between the on and off-pump groups in both females and males. Pump status was not associated with significant differences in all-cause mortality for females, shown in the survival curves here, as well as for males, shown in the survival curves here. Women who underwent multiple arterial grafting in the off-pump group were associated with a significantly increased risk of MACE. There was also a consistent direction in the association between pump status and MACE in the individual components of MACE, but no statistically significant differences in each individual outcome. Pump status was also not associated with differences in MACE in the males. Overall, we see that all-cause mortality was not different between pump status for males and females. Concomitant use of multiple arterial grafting in off-pump surgery may be associated with an increased risk of major adverse events in women, but these results may reflect technical challenges, as the outcome differences by pump status was not statistically significant when the analysis was restricted to high-volume centers. Thank you.
Thank you very much, Dr. Cho. So does anyone? Thank you.
Thank you. May I make a very quick comment?
Yeah.
So thank you everyone for being here at 7 o'clock on a Sunday morning. You all deserve a medal. But anyway, so what's great about your study is I think it's completely true of bypass today versus non-bypass. If you had done this study 20 years ago, there would have been a high chance you may have seen some differences. Today, cardiopulmonary bypass is so safe that it's very difficult to distinguish a difference between bypass and non-bypass. The one still important area is to avoid aortic manipulation. But in my practice now, so I'm a very keen proponent of off-pump surgery. But today, to me, is far, far more important to say to the patient, we're going to do 3 arterial grafts, than whether you do it on pump or off pump. Thank you. And thank you for doing this at 7 o'clock on a Sunday morning. And lovely presentation. Very well done.
Awesome. Thank you so much for the opportunity. Thank you.
Thank you very much.
I would echo
Sort of a
those,
comment
I
on
would
that.
echo those comments
you.
by Dr. Taggart. I just wanted to share with the group that in the United States, the off-pump rate is significantly lower than obviously what you guys reported. We have about a 9% rate of off-pump surgery across the CABG population, and that has probably decreased by about 50% from a high of about 20%. So I guess the question is, what would you recommend in terms of the optimal grafting strategy for folks either off-pump or on-pump? And is there a subset of individuals that would benefit from off-pump in addition to those individual surgeons that are high pump users?
Awesome. Thank you so much for your question. And that is a great question because as we see here in sensitivity analysis, when we excluded the surgeries from centers who performed less than 550 multiple arterial grafting cases, we saw that there was no significant differences in MACE in women. And so I think considering the technical challenges with off-pump surgery itself, as agreed with Dr. Taggart and what he's saying, is it's better to perform a safe surgery that will last them for their lifetimes, and that's multiple arterial grafting. But I think considerations with patients with high risk for stroke and those aortic porcelain aortas, in those kind of cases, then potentially a no-touch off-pump strategy would be optimal to minimize their risk for stroke. So thank you so much.
Thank you very much for a nice comment. So the next will be absent, and so the next move to the 18. So I'm to reduce the cuts of time, and I will call the just name, not title. So Dr. Ravi Shankar.
Yeah.
Thank you very much.
Hello, thanks very much for the opportunity. My name is Ram, I'm a resident in Glasgow in the United Kingdom, and my project is on the sex-specific outcomes of purely internal thoracic coronary bypass grafting, which we do in our centre. Don't have any disclosures. Now, it's a form of multi-arterial CABG, and I suppose most of you are probably familiar, but how we do it is we have a a pedicalized lead, not skeletonized, and a free retest, a T-graft, and we use that to anastomose subsequently. But we do know that sex-based outcomes have been often represented in recent trials, and there's increased recognition that there's clear disparities that need to be assessed, such as the Roma Women trial that's running at the moment. So what we wanted to do was to assess the outcomes in our centre following Peter CABG. It's a retrospective analysis of 843 patients between 2012 and 2023. We used one-to-one propensity score matching, but we had the logistic Euroscore that was collected in our centre. We used the chi-square and Fisher tests, and our primary outcome was all-cause mortality. And we also looked at stroke, infection, and AF rates. Now, probably the first thing to look at is that cross-clamp and bypass time was significantly lower, but that does reflect the number of anastomoses performed per gender. We had 140 in each arm, and there was about 3 median anastomoses in the female cohort compared to 4 in the male cohort. There was no difference in infections, either deep sternal or superficial wound infections, and we had no incidence of pneumothorax or stroke afterwards. We did do a Kaplan-Meier analysis and a Cox analysis too over 10 years, and what we found was that, interestingly, it was significantly a higher mortality for the female cohort in 10-year follow-up. And we went to have a look at the predictive factors. The gender was a predictive factor significantly when assessed, when adjusted for the Euroscore. And you can see the hazard ratio just over there of 0.27. So in our study, in our centre, the female sex was associated with a worse 10-year survival with Peter CABG in a single centre study, and they also had a significantly lower number of anastomosis or grafts for Peter CABG, but we do recognise we do have some limitations. There was a single surgeon bias. We used the log Euroscore as a propensity score matching analysis. But hopefully further trials will help answer this question, such as Roma Women, and we look forward to seeing what the results of that are shortly. Thank you very much.
Thank you very much. So that comment, please.
Great presentation, thank you. The amount of anastomosis is clear that there was a difference, and was there also a difference in completeness of revasc?
No, so there was a difference in the number of grafts we did, but in terms of revasc, the only marker we have is PCI afterwards, and 3 patients out of 843 had PCI afterwards. So that's kind of our marker of seeing whether there was complete or incomplete revascularization.
And you have any
from the study.
idea on the targets? Were there the same amount of preoperative targets, potential targets?
Yeah, so
or
we do have the target. So, I mean, the LAD was always done in the majority of the patients. Some had an intermediate that was done as well. So the left would be used for the intermediate diagonal LAD. OM right would be with the right of the T graft. But you're right, that is something that we can analyze and present in future meetings. That would be good.
Thank you.
Thanks.
Thank you. If I can please make David Taggart, Oxford, if I
Of
can make
course.
a quick comment. So thank you for your wonderful presentation. What you do not separate out, as I understood the presentation, is what are the innate characteristics of women that make the operation different from men. And I may have missed it, but I didn't clearly understand that.
Yeah, so I suppose there's a few things that we can allude to. I mean, things like smaller coronaries is one thing that we can see. I suppose how atherosclerotic plaques progress, I think there's some evidence that says it's more diffuse than focal disease. So that might be an indication of why you have a reduced number of anastomoses compared to the male gender. But these are all pathophysiological, from what I understand, differences-wise.
So in your average woman patient, I don't mean somebody who's extremely obese or who has diabetes or bad lungs, what would your cabbage strategy be?
Yeah, so I think it would depend per center, particularly in the United Kingdom, as you know. I think it would be good to obviously keep your arterial-wise. I'm not too sure if multi-arterial grafting does have a benefit from our study or from, I guess, what we've seen already. So I'd be a proponent of whatever your current practice is, to be honest. I think, in our center, we would just, we'd go for a Lima and 2 veins if there's another surgeon or...
Okay, so if I may please, Mr. Chairman, very quickly ask this question to this audience who have turned up at 7 o'clock on a Sunday morning. If you have an average woman, so not grossly obese, not severe diabetes, should your strategy for grafting be a single mammary in 2 veins, or should it be multiple arterial grafts? So the question is, if you think the best strategy is a mammary in 2 veins, please raise your hand. Okay, well, yeah. If you believe the basic strategy for the average woman should be multiple arterial grafts, please raise your hand. Okay? Dr. Schwan. Tom, sorry, your microphone's not working.
So there is some data to suggest that multi-arterial grafting is actually more beneficial in women than in men. And I think that, under these circumstances, I think that it should be the default strategy to optimize whatever the platform that you're most comfortable of multi-arterial grafting, whether it's beta or radial, and you can adjust that based on the risk of deep sternal wound infections to whatever the strategy that you might have. But I think it's important to make sure that females get the same multi-arterial grafting strategy as men, even though if you look at the national databases, the rate of multi-arterial grafting in women is significantly lower. It's increasing, but it's significantly lower than men.
Yeah, I think that's I agree. Yeah, thanks.
Thank you. Shazad Raja from Harefield in London. In response to your question, David, I think we've all agreed that multiple arterial grafting is the way to do it. However, the issue is that we're not able to convert evidence into practice. And the big problem is that we're not trained to do this operation. I think not every surgeon can do this operation, and we're not training people to do it. If 4% of the surgeons in the States and 10% in the UK are doing multiple arterial grafting, I think there's a fundamental problem. And the fundamental problem is that we're not training people to do the best operation that we should be offering to our patients. And the only way we can do multiple arterial grafting and off pump in somebody who needs it on a certain day is by ensuring that all high volume centers have a subspecialist coronary surgeon. I think the way forward is subspecialization in coronary surgery. If we're not going to train people to do these complex operations, we will eventually potentially lose coronary surgery to our colleagues in cath labs. And I think if you believe what our friendly cardiologist Patrick Soroy says, 2040, the landscape of coronary surgery is going to be completely different from what we do now. So I think it's high time. We're now in the 11th year of ICC. ISCAS has done a lot of work. I think the way forward is to now push for coronary surgery to be recognized as subspecialty. If the mitral surgeons do 40 operations a year are subspecialists, why not every unit have a specialist coronary surgeon who can do the full spectrum of coronary surgery, from an on-pump CABG to robotic, endoscopic, and aortic off-pump CABG. And I think the way forward is subspecialization. So thank you very much.
Thank you, Mr. Raja. Thank you.
The quick comment, please.
Just a very minor point that I wanted to raise, since the significance of breast cancer is also quite important. We should also pay attention to that part where the graft could be impaired by radiotherapy or previous interventions. Yeah. And that should also influence our decision-making probably around the surgery. We need better tools to evaluate the grafts, the choices of grafts that we are making, and the way that we take out our grafts, I think.
Yeah.
Thanks. Sorry, just to add one more thing. For Fraser Rubens, University of Ottawa Heart Institute, in Canada, our incidence of multiple arterial grafting, 2 or greater grafts, is between 35%, and that's in all across Ontario. In my personal practice, it's like 80%. The reason is not you need to be super trained people. We have great surgeons who do lead in vein. They don't do it because there's not necessarily a financial advantage. There's pressures on the system because it takes longer to take a second mammary, et cetera, and there's no incentive. And in the United States, you've built a system, or you're suffering under a system whereby you are penalized for getting wound infections. And that is wrong. And if you didn't have that problem, you'd have multiple arterial grafting, I guarantee you. That's your own system that's causing it. It's not hard to do multiple arterial grafting. I mean, it's fun. You can do it. You can train people to do it. We train our residents to do it. And I don't think you need a specialty team to be doing it. You have created the problem because you have to fix your healthcare system.
Thank you.
Thank you.
Thank you very much. Okay, so it's time to move to next presentation. So 19, Dr. David Icke. Please start it.
Thank you very much. My name is David Icke. I'm a cardiac resident from Royal Papworth Hospital. I'm also the co-founder and CEO of the London School of Cardiothoracics. I'm very excited by thank you for the opportunity to present. I'm very excited by the previous presentation because I'm about to discuss what Mr. Raja has just talked about, which has to do with training in cardiothoracic surgery. And I have nothing to declare. So, coronary surgery training, are we leaving it too late? Now, in the world, in the current situation that we have a PCI versus CABG debate, there's a gap that we don't talk about, and that has to do with the standardization of training modalities and how we train our trainees and residents coming through. And there is data to suggest that we are choosing surgeons wrongly. First of all, we focus a lot on aptitude testing versus cognitive attributes, and aptitude testing versus innate surgical ability. And there's also data to suggest that 10% of surgeons who are technically gifted and are amazing surgeons, the other 80% are really good and are decent surgeons, but we have a 10% cohort that should not be surgeons at all. If we're talking about multi-arterial grafting, off-pump surgery, if we're talking about robotic surgery, we need to choose our surgeons based on innate surgical ability, and it's important that we identify these surgeons early, and I'm talking about all the way back in medical school, cultivate this innate ability, and other factors will provide a robust substrate for surgical training. Now, our center, London School of Cardiothoracics, we've been running coronary-focused workshops for the last 5 years. And here is our experience. We've also recently started working with My Virtual Surgery by Professor Jean. And this is a 5-year experience from the feedback from our scores. We have divided this into coronary training for senior residents and coronary training for junior residents. And what we can see is there's been a consistent, over the last 5 years of data, there's been a consistent self-improved rated ability after each of our courses. But the problem with these courses is they're extremely resource heavy, resource intensive, and it's not available to everyone. And so the question is, what do we do about this? Because we have to find a way to standardize and improve our training modalities. Now, also over the last 5 years, we have worked with different companies to create different training modalities. So the top 2 photos that I show you is a work that we did with the Cardiac Advanced Life Support, the CALS group. We helped them build an augmented reality platform, which we are going to help them now turn into a virtual reality platform. And this is to train critical care doctors who are providing cardiac focused care. At the bottom left, you can see our training of medical students on basic suture technique using smart glasses. This was done remotely, so each of these students had smart glasses, and you could watch them in real time as they performed their suture technique. Now, the important thing was whoever was training them got to do this from the comfort of their home. They didn't have to be in the same room as the medical students. And the bottom right is our experience with virtual reality. We have been running a virtual reality research for robotic surgical training over the last 5 years as well. And we've actually created a standardized curriculum for basic robotic training, but for thoracic surgeons. So the question is, what are we going to do about cardiac coronary training, so CABG-focused training? And so our idea is to create an AI-driven virtual reality educational platform. And this platform is to focus on open and robotic cardiac surgical training. And the idea is to widen access to surgical training for everyone, because we want to start again at medical school. And we want to ensure that this ushers in the era of VR, AR, and AI systems in coronary training. So what is the CABG Surgiverse in a nutshell? So if you just have a look, these are all the methods of training that you can think about. There's the Halstadian model, obviously, see one, do one, teach one. You can see just what I've put over there on the left side. So challenging tasks, repetitive practice, immediate and informative, feedback, safe and ethical, all of those are factors for excellent training. And you can see that all the methods of educational training methods we have do not tick all the boxes. But if we're able to create an AI-driven virtual reality platform that provides training to everyone in real time, expert feedback, safe, ethical, at the comfort of their homes, we will be able to train our surgeons much earlier and provide standardized surgery for in the CABG world. So our call today is to you all. We can't do this alone, and we'd like to, if you're interested in this field, if you are a surgeon who's looking for improved modalities, please reach out to us. And that's the end of my presentation. Thank you very much.
Thank you very much. David, please.
Thank you. If I may make a quick comment, and to you, David, I admire enormously what you're doing, and you deserve enormous support. But you know, we in cardiac surgery are different from a psychiatrist. If you go to psychiatrist A and psychiatrist B, whatever they tell you isn't at the end of the day going to make much difference. But I would prefer, if I needed an operation, to go to a cardiac surgeon like Dr. Faisal Bakin, extremely skilled in what they're doing, and I couldn't give a toss about their personality. It's irrelevant. When you're flying across the Atlantic, what you want is a pilot who knows how to fly a plane. If you want to do a personality test, that's totally different. But I think it's very dangerous to try and minimize the expertise of a cardiac surgeon. So for example, if I needed minimally invasive coronary surgery, I'd go to Dr. Sam Balke, Dr. Faisal Bakin, Dr. Gianluca Torregrossa. But you cannot, and it's dangerous, to try and equate this some way into personality. If you're talking about psychiatrists, fine. If you're talking about a doctor who's a general physician, who gives you a tablet that's either blue or green or red, fine. You cannot reduce that aspect to the immediate aspects of what is the technical importance of cardiac surgery. But thank you for your great presentation.
So, Prof. Target, just to respond to that, I totally agree with you. Actually, that's the basis of my presentation. My presentation is that the problem is we're choosing people based on how well they interview, and what I want us to do is pick our surgeons based on how well they operate. And the idea is if we get them extremely young, right, then we already know through these platforms that we have trained a cardiac surgeon already in medical school on the basic techniques using all these methods that we have there. And then when they come in, then to your practice, I come in, as a resident, then you can then focus on fine-tuning my skills when I am a resident.
David, with all due respect,
Yes.
it's like if you took 100 people off the street and said, you've never played the piano,
Yes.
try and do a piano tune, you'll see a Gaussian distribution of innate skills. And people who do cardiac surgery, you can't train it. They either have those skills or they don't. Thank you.
Yeah, thank you.
Great presentation and very interesting work. I think the idea of adding AI in guiding this learning process is very, very interesting and very future-proof, probably. But how is your plan to motivate people? We are working a lot on training. We are offering a lot of tools also, and they look fantastic. They're very real life-like. You can make them really like in the operating room. And then people are very interested for the first time, and then they lose interest. And so they don't go through the intended learning curve as they should, because they think, yes, I can do it. So how do you motivate this strong opinion cardiac surgeon to go through a learning platform that you're creating?
Thank you very much for your question. And again, this is why I don't think it's... So I'll start with, who's the best soldier? What's the age of the best soldier? Do you know? The best soldier is, you pick them between the ages of 20 and 25, right? Those make the best infantry. They're superb. And the US military has a doctrine based on that. The reason why anyone above 25 becomes very difficult to train. I'm not asking us to train residents. I want us to focus on those people who are in the first year of medical school. I think if we made surgical technique as an important part of medical school training, then we can tease out all of this, because then the motivation is, if you don't pass your surgical training exams in medical school, then you're not going to be able to apply for a surgical specialty. When you're already a resident and you're going to go into theatre tomorrow, it's very difficult for me to give you a VR headset and say, well, go and practice and show me that you're really good, right? And that is the difference. That's where we want to target this. We want to go far earlier in the training curve.
I fully understand why you want to go young. Do you think that they will keep those capabilities when they are going to go to their first patient? And are they fully then ready and prepped to dive in? Do they need any rehearsal? I mean, we are training medical students then, and it's still a long way for independent surgery. So how do we define the milestones that they have to pass? How do we do quality check throughout the process? These are things that I'm certainly interested in.
Exactly, and this is part of the research that we are we want to perform. The beautiful aspect of this is that AI gives us the ability to automate the process and ensure that there's quality. The quality remains high throughout. The second thing is we need to create for basic surgical training and then coronary training and so on and so forth, we need to create a gradation. Just like when you're learning the piano or any musical instrument, you have different grades that you have to go through. And if you've been through musical instrument training, you don't lose those skills. If you've hammered it in over 5 years, of training, or 5 to 10 years, if you put in your 10,000 hours, basically, that surgical skill does not go anywhere. So our feeling is that we target it early, we create a standardized curriculum that we can all agree, and when your resident comes into the OR, you're not going to be teaching them how to hold a Castro, right? You're going to be teaching them, okay, well, we're going to have to do multiple arterial grafting. They already know the technique of how to do it. Now you're going to guide them on the steps, the clinical decision making. So this is sort of where we're going. We don't have all the answers yet as well, because this is all new, and we're trying to build this, and we want such feedback. So thank you very much for your comments.
David, if I can make one final comment, I'll
Yes.
keep it short because we're running out of time. I was very privileged as a trainee to work for the fantastic, great man, Professor Sir Magdi Yaqub. You can do all the personality tests, all the things you're doing, they're all totally irrelevant. You cannot try and train people who don't have the intrinsic surgical skills to do operations. If you come into my operating room, I will tell you in 20 minutes whether this person's ever going to be a surgeon or not. Now, of course, you can introduce all of these things you've described, and I do congratulate you for addressing the issue. But the point I'm making is, if you're a Professor Sir Magdi Yaqub, nobody can train you. That man had enormous intrinsic skills. He did things I've never seen any other surgeon doing. And there's no way any number of tests you can do can identify someone like him. So so it's different from other branches of medicine where you can definitely influence. So sitting talking to a GP, general practitioner, how good is that person communicating with you? And for most problems, communication is very important. But if you need a heart operation, the personality and the bedside manner of that doctor is totally irrelevant. What you need, even if he's the most, if I may use the word, shittiest person you've ever met, but if you can do a great operation, that's what you need.
Again, thank you, Prof. Target. And again, we totally agree with this. I personally don't care about the personality of our surgeons. And the wonderful thing going forward is that AI is going to be the interface between our patients and us before our patients come to see us. We need to focus on innate surgical ability. And again, there's data to suggest that 10% of surgeons are innately gifted, like your Prof. Yaqub. And then you have 80% of surgeons who have decent surgical capabilities. Then we have a 10% that should not be in the operating theatre at all. And that's what the data that has been in multiple studies that we've viewed have shown. The problem is we don't use technical testing. We don't test for innate surgical ability. Your residents come to your theatre. You've just said when a resident comes into your theatre, you can tell if they're going to be a good surgeon or not, right? But the problem you have at the moment is when you can tell if they're going to be a good surgeon or not, it's already too late, right? You're going to have to train this person that you think is not going to be a good surgeon. Now, the idea is, well, why don't we figure them out far earlier in the curve? Why don't we tell them already in medical school, you don't have innate surgical ability, why don't you forget about this? And then those who have decent surgical ability, let's get them in medical school and say, well, we can train you up. And those who are well gifted, we can identify them early and stop them from becoming cardiologists.
Thank you very much for deep, very important discussion. So we have to move the next presentation. So Dr. Pettinari,
Yes.
please.
Good morning, everyone. So we want to present with these slides our initial work in try to measure intraoperative intracoronary flow by high frequency ultrasound. So as you know, the coronary imaging is improving fast, as we also was presented in the last days with the CT, with IVUS, with OCT, but also as a surgeon, we can have an imaging system in our OR, and for example, the Medistim system with the MiraQ, and using the flow probe to measure the flow inside on the graft, but also the imaging probe, the high frequency ultrasound. And as published already recently, from the French group, this also has an impact on clinical outcome. So the aim of the study was to test the hypothesis to measure intracoronary flow by high-frequency ultrasound using the high-frequency ultrasound probe with the functionality on the 2D functionality and the pulse wave Doppler functionality. And as routinely we do, we measure also the graft flow, the PI, the diastolic filling and the insufficiency percentage. Just a very basic concept from the physics. To measure the flow, you need just two parameters. There are the cross-sectional area of the vessel and the velocity inside of the vessel. And usually you can have the average velocity to measure the average flow in that vessel. And so what we do also, we try to quantify the stenosis in a cross-sectional area of the graft. I don't know if you can see my arrow, no. So this is a vessel that was with the transverse cross-sectional area of the place where the higher level stenosis was present, and theoretically we can also measure the percentage of the stenosis of this vessel. There was the LAD, and for example also on the lateral wall. And then we pass on the target vessel and the target segment of the coronary artery where we want to graft, and then we measure the cross-sectional area of this vessel. And this was also on the lateral wall, on the infralateral wall, with a very small vessel, so this is still possible when you performing off pump and with the stabilizer on the surface of the heart, and then with the pulse wave functionality of the echo of the Medistim, we can use the intracoronary velocity of this vessel as presented here. There was 46 centimeters per second. Here is another example again on the lateral wall where we measure this kind of velocity. And here is a bad example because also with the stabilizer on and the vessel was quite tortuous, so it's quite difficult also in some case with the actual probe when the vessel is very, have a lot of curvature, let's say, to have a nice alignation of the vessel and to have a nice trace of the velocity. So this is the example of the coronary surgery we have done. We perform in a 65 years old patient a triple arterial graft. We perform in the Y graft first and with the in situ right mammary artery, and then we perform a Lima to LAD, and then the second graft to the inferior and infralateral wall. I cannot advance the video, unfortunately. Sorry for that. Okay, we continue. So the idea is also to, we systematically use the DTFM to check our graft, but for this kind of study that we are going to run, we are also interested not only on the flow and the PI and the diastolic filling, but of this important parameter that is very tiny presented in the slides. So the percentage of the insufficiency flow, so the backflow that you have in your graft, because this could be also correlated to the dimension of the graft and the flow inside of the graft. And here is also another example where we have nearly zero competition of flow measured by the insufficiency percentage. And this is the first two patients that where we perform this kind of measurement, where we have the area, the Doppler velocity, and the flow of the intracoronary artery. And these data we are going to correlate with the flow inside of the graft, the competition of flow as we measure, and we hope to find some correlation and some insight on that. So the frequency ultrasound allows intracoronary derived flow measurement, coronary dimension evaluation, and coronary stenosis quantification. Those measurements could be correlated to the graft flow and the competing flow percentage, as say. And further studies are needed to evaluate the impact on angiographic and clinical outcomes. And I think we could improve the planning for graft construction and deployment, because I think we heard a lot as tailor to make a procedure tailor for the patient, but I think there is a next level to tailor the procedure to the coronary target as well. I thank you for your attention.
Yes,
Matteo,
comment, please.
Fantastic work. You're a great off-pump surgeon. And did you use your probe also to estimate the size of the target and your shunt choice? Did you correlate that clinical choice towards the measurement on echo?
The measure are after that we performed the surgery. The measure were done in the office, let's say, not directly in the because our time consuming is still time consuming, and directly with the Medistim you can measure, but it's going to take a lot of time.
And do you think it might be just as accurate for the size measurements, or is it difficult to make a real accurate estimation?
If your image has a good quality, I think the definition, the resolution of the probe is enough to measure the lumen of the coronary.
What I like very much in your work is the dynamics that we can finally grasp a bit in this kind of model. Would be very interesting to see also how the flow through the graft and through the coronary goes and then evolves after opening the bypass combined with the construction. I think this is where AI could help us really tremendously for estimation of what is successful and long-term interesting. So great work.
Thank you, Walter.
Thank you. Thank you for a great presentation and a very important presentation. But whoever is doing your images needs to wake up, because those were not great images that you presented, in my opinion. But the real critical question I have to ask you, so I do about 90% of patients off pump. I do think there are patients who are definitely better done on pump. But the technical question I would like you to, if you can answer, so I can always get a pretty good image of the Lima to the LED when off pump with the heart beating. But I really struggle to get that image for the circumflex system and the inferior wall. Do you have any tips and tricks as to how to do that?
The struggle is the same, I have to say. I think the probe need to improve when you're going on the lateral wall and the inferior wall. I'm just thinking just the last week, eventually, you know, there is the metal ring on the probe.
Yeah.
That is the only really solid part where you can grasp with some solid forceps. So I was just thinking eventually to put a sort of tourniquet on that to have the possibility to also, when you are just 2-3 centimeters of space, to move a little bit and to change a little bit the orientation of the probe. But the struggle is there, and you need a lot of gel on the lateral wall, this glide down on the pericardium. So it's just a starting work, let's say. Andy, sir.
Thank you for a great presentation.
Thank you very much. So the next presenter is Eli Aksoy? No. Okay, Dr. Ala Abdul.
Demirözü,
Yeah.
DMR. Good morning, everybody. I would like to thank all the organizers and moderators for this meeting. Our paper is coming from Istanbul, Turkey, from Koç School of Medicine, American Hospital. The aim of our study is to investigate the illustration of the extubation in the operating room and with off-pump coronary artery bypass grafting. This is a retrospective study with 484 patients who underwent elective, urgent, and emergent total arterial vascularization between November 2015 to December 2022. We usually, as a group, do off-pump CABG since early 2000s, and we are just, our favorite grafts are BITA and complementary graft. We use radial arteries. So thoracic paravertebral block and erector spina block were administered with ultrasound guidance in all patients except those who were hemodynamically unstable. And the anesthesiologists do the preoperative paravertebral block, and before the extubation they do another block with intercostal blocks, bilateral between T7 and T8. The mean age of our patients were 62, and 424 patients were males and the rest were females. The operation was elective in 6% of the patients, urgent in 30% of the patients, emergent in 2.7%. Bilateral internal thoracic arteries were used in total of 75% of the patients, and 43% were used as composite grafts, and 32 were used as inside grafts. Aortic no touch was employed in like 68% of the patients. After completion of surgery, 91% of the patients were extubated in the operating room and transferred to the ICU. None of the patients were intubated in the ICU, and 2 patients died. One died because of pulmonary embolism on the postoperative 3rd day. The other patient had died intestinal sepsis, pneumonia, and multi-organ failure on the 3rd day after the surgery. The mean time for the ICU was 24 hours. The mean length of the hospital was 5 plus minus 4 days. These are our demographics and operative data tables. So this is the paravertebral block and this is the extubation in the ICU. And this is the same patient just doing the spirometry in 1 hour after the surgery. So conclusion, we believe that routine extubation in the operating room following off-pump CABG is both feasible and safe with the help of regional blockage and helping the patient comfort and for the enhanced recovery surgery. Thank you.
Do you have any comment, question? That's fine. Okay, sorry, we're running out of time, isn't it?
Thank you.
Yeah, maybe to the next presentation. The next is the Dr.
Thank you very much for the invitation. My name is Abdel Al. I am a cardiac surgeon from the Charité Berlin. I would like to present you today our concept which we called protected CABG or Impella. What we know in this field that patients with CED and severe reduced LVEF, they have quite high mortality rate postoperatively, and what we know also that in the interventional field that protected PCI showed very promising results. So why we came with this concept, we did 2 studies in our clinic, which we saw that patients who were like operated in the on-pump beating heart had better survival rate than patient with cardioplegia, and a second study which we published last year with one clinic in Germany, the Bad Oeynhausen, where we compared patient with LVAD implantation and CABG with ICM propensity score matching from 168 patients. We showed that the survival rate in the CABG patient after 3 years was way better, but what was very interesting in this study, we saw that the temporary mechanical support implantation was in the CABG cohort quite high, and also the renal failure. And in this cohort, like the 168 patient, most of the patient got on-pump beating heart. So what we do now, we thought why we don't support those patients not only postoperatively but also perioperatively. So we did in our clinic SAP what we call protected CABG. So what we're doing, we don't just run the normal evaluation tests in those kind of patients according to the guidelines. We do actually the complete LVAD evaluation test, so that we prepare those patients also mentally for postoperative LVAD implantation. I would like to present you 2 cases from our clinic to show you that we need intensively more evaluation in this field. In the next year, we have 2 patients with almost similar profile. We're talking here about ventricle diameter from over 75 millimeter, and as you can see, the patient number 2 has higher comorbidity. Here are the echo from the 2 patients, and you can see here in the angiogram that patient number 2, he has not so optimal target, and I had through operation more challenges like doing the bypass with this patient. Here is also the right coronary, the MRI, and what I did in those two patients did 5 bypass exactly, almost the same targets, here I thought from the results that the patient number 2 is going to have not really to have a good weaning from the Impella, but what was not expected that the patient number 1 couldn't have cardial weaning, and he got LVAD after 10 days from the surgery and could charge after 30 days, and the second patient had really good cardial weaning and could leave the clinic after 18 days. So in the last 2 years, we did 25 patients. As you can see here, we're not talking about a normal cohort. We're talking about very sick patient with median left ventricle diameter from 75 millimeter. 1 patient died because of pneumonia, and 20 patients could go home without an LVAD, and 4 patients got an LVAD, but also left the clinic with no complication. So here is a picture from our operation field, and I wanted to show you here also like how we do it. You have really good hemodynamic, you have a really good approach to the lateral wall, and here also you have a really good approach to the posterior wall, and here like the best message is that you have like during this operation, this approach, you have like perioperatively and intraoperatively mechanically support. You have easier approach to the lateral and posterior wall. You can, we extubate this patient very quickly. We start already on the first day our medical therapy. We mobilize the patient actually in the first day, and you can continue with your evaluation for like further therapy. And I think what we could show that you can delay also like LVAD implantation for maybe several years, or maybe they don't need it in the future. So that's it. Thank you very much.
Thank you very much. So the quick comment or question, please.
Yeah, just quickly. Those impellers are placed pre-op preemptively, correct?
Perioperatively, yeah.
And are all those patients okayed for possible long-term VAD before you put in the impeller? Because you don't want a bridge to nowhere.
If they what? Sorry?
Are they approved by the multidisciplinary team for a permanent VAD?
Yeah.
Insurance and everything is checked?
Everything is checked.
Because the way we do it at our institution is that we need to approve them socially, economically, administratively, by the insurers, etc. Because
like
if you put an impeller in
Germany,
them and you can't wean them, and they don't approve a VAD, and the patient can't pay for it, unfortunately, it will be a bridge to nowhere.
Yeah, it's interesting. It's not the way that how it works actually in Germany.
Yeah.
So it's we have also like a matter of cost. So if you do like 2 operations, you're going to lose money. But for this kind of operation, we could show like through our study that this patient has really like long stay in the hospital and a lot of complication. So we could manage that with the insurance company that we cover all the cost. But
yeah, unfortunately, as much as we would like to take cost out of it, the reality is it somehow figures its way in. Fantastic talk.
Yeah, thank you very much.
Thank you for a great presentation. When I hear many talks like this, as a practicing clinical surgeon, the one thing that doesn't often come over to me is what were your distal targets like? So if you've got a bad ventricle, but good distal targets, it's a very different operation from having a bad ventricle and poor distal targets.
Like in induced patient, mostly they have really not so good targets. So it's always actually challenging. So and it is actually also almost a one-man show that you have the best surgeon in the clinic who make a bypass and you give him to do this because you want it to work, actually. So
I agree, targets are the most important, even more than viability.
Yes.
But what you really have to also pay attention to is cardiomyopathy out of proportion to the severity of coronary heart disease. That's when an MRI would be useful to identify alcoholic or other kind of forms. They can't specifically.
But this is what we can see, actually. We can see that we run MRI on all of those patients and we have a good viability, but we still have like 20% of the patient who got an LVAD at the end. So we need like further. We are working on it now. We will run another study where we can find more parameter in the MRI, so which can help us induce.
Thank you for a great presentation, so very well done. But please, next time you do your presentation, say, we looked at the angiograms and the reason we went ahead with the operation.
No, we do. I show it in the picture. We do.
My apologies if I missed it.
We do in all of this patient FFR measurement. So we do FFR measurement, strain ratio, MRI, and we do all the evaluation for the LVAD. Like
MRI, ischemia testing, viability testing, in my opinion, irrelevant. They don't change my decision. What I want to know is, does this patient have a subsequent, a significant volume of anatomic disease in the coronary arteries? and are there things that I can graft? Many of these presentations are excellent, but what they don't tell me is what I want to know. Are these graftable vessels?
We can give them bypasses, but we can't give them targets.
Correct.
Exactly.
Well done.
Okay.
Thank you.
Okay, thank you very much. So next presentation is Dr. Sugiyama.
Good morning. Thank you very much for inviting me. It's my pleasure to share work with you today. I have nothing interest to disclose. CABG is known to be superior to guideline-directed medication therapy and PCI in low-EF patients, as demonstrated in this trial. However, the surgical strategies differ by surgeon and by center. This study is to compare clinical outcomes of on-pump-baited CABG versus off-CAB injection fraction less than or equal to 35% using propensity score matching. This was a single-center retrospective study performed past 11 years. 357 patients underwent isolated CABG, and 45 of them had an ejection fraction less than or equal to 35% were included in the final cohort and divided into two groups, on-pump baiting group and off-CAB group. We performed one-to-one propensity score matching, including mitral regurgitation, moderate to severe or higher, and triple vessel disease as covariates. Since those are the only variables that differed between these groups before matching, we included them in propensity model. Primary endpoints are 5-year survival rate, and secondary endpoints were MACE-free and cardiac death-free survival rate. MACEs were defined as follows. After matching, there were no significant baseline differences. Off-CAB showed no less blood loss, required fewer RBC transfusions, and had a short operation time. But graft strategy and number of anastomosis were comparable between these groups, indicating a similar degree of completeness of revascularization. 5-year survival showed significantly higher in on-pump beating group. Cardiac death-free and MACE-free survival were comparable between these groups, but still both curves trended in favor of on-pump beating CABG. It's worth noting that several causes of CAB group were unrelated to cardiac causes such as COVID-19 infection and malignancy, which may partially explain the differences occurred in off-CAB group. We performed sensitivity analysis using 3 different types of Cox hazard models. All models show hazard ratio below 1, consistently favoring on-pump beating CABG, but they did not reach statistical significance due to the small sample size. In conclusion, on-pump beating CABG improves 5-year survival in low-EF patients. Our results were consistent with prior reports. On-pump beating CABG may offer a reasonable option for low-EF patients requiring complete revascularization. Thank you very much.
Thank you very much, Dr. Sugiyama. David, please.
Thank you. If it's okay, sir. So thank you for a wonderful presentation. But I am disappointed you don't know the evidence in the literature. So my group, published a randomized trial in Circulation in 2008, showing that if you do on-pump beating heart, your patient will survive. But if you look at the amount of myocardial injury, defined both biochemically and by MRI scanning, what we saw, so the intuition do it on pump beating heart is great. That's why we did the trial. But what we saw was at 1 week and at 6 months, there was a far higher incidence of apical subendocardial infarction. So what was happening was when you've got a patient with an LAD stenosis of 90% and maybe something distal to that, the actual apical perfusion pressure is probably 10 millimeters of mercury, and these hearts are beating. So what we saw was a far higher instance of myocardial injury in those patients. So you present your data, which intuitively, and thank you for a wonderful presentation, but I think you're ignoring something that is potentially very important. And I tell you why it's important. If you look at the patients in our trial, when they were analyzed by MRI 6 months after the operation, so not 1 week, not 3 weeks, not 6 weeks, 6 months after, they had significantly impaired ventricular function compared to the patients who had cardioplegic arrest. So I like what you're saying, and thank you for our great presentation, but I think this is potentially dangerous to the message you're giving. Thank you.
Okay, thank you very much. So the next presentation is Dr. Seleser.
Good morning, everyone.
Yep.
I talk about how to deal with moderate ischemic mitral regurgitation in patients undergoing CABG. I have no disclosure for this topic. So the treatment of moderate ischemic mitral regurgitation during coronary artery bypass grafting is still debated, not only in terms of to repair or to replace the valve, but also if to treat or not to treat the valve. The aim of our study was to assess the benefit of myocardial vascularization on the mitral valve function. So to do it, we have decided to assess the changes of mitral valve reserve over time. The concept of mitral valve reserve is based on the mechanism of anterior leaflet compensation as a consequence of posterior leaflet tethering caused by the dysfunction of the posterior papillary muscle and the posterior lateral wall due to an ischemic injury. The original formula, as you can see, to calculate mitral valve reserve is too complex to be used in the clinical daily practice. So we decided to simplify this formula like a ratio between the anterior length, anterior and posterior leaflet straight length. In end systole, in 4 apical chamber view, we measure the anterior leaflet straight length, the posterior leaflet straight length, and so we calculate the ratio. It is clearly obvious that this ratio increases when the posterior leaflet is pulled down by the tethering forces, and this ratio decreases when the posterior leaflet starts to move again as a consequence of the recovery of the left ventricular papillary muscle and wall function motion. So we enrolled 160 consecutive patients undergoing CABG with moderate MR. These are the inclusion criteria. And we have seen that the mean mitral valve reserve statistically significant decreases over time, remaining stable at 5 years follow-up. The ejection fraction statistically significant improves over time as a consequence of a ventricular reverse remodeling process, probably. At 5 years follow-up, all patients had mild mitral regurgitation and are free from need for mitral valve surgery. So in conclusion, we think that the benefit of myocardial vascularization in terms of improvement of mitral valve regurgitation degrees can be explained by the changes of mitral valve reserve. Our results remain stable at 5 years, suggesting that in this selected patient with only moderate ejection fraction reduction, only good target vessel on lateral posterior lateral wall, no dilation, only moderate dilated right ventricle, CABG alone could be enough. Thank you very much.
I'm here just to advance the timing. It was a great presentation. Any question from the audience? Yeah. Please. Thank you so much.
Thank you.
Thank you.
The please next presentation is Dr. Chen.
Good morning, everyone. I feel honored to be here for this presentation. Today, what I'm sharing is therapeutic strategy for moderate ischemic mitral regurgitation with coexisting heart failure and impaired left ventricular ejection fraction. I have nothing to declare. Here is the overall of our study. Population and method from 2010 to 2024, we include patients who undergo CABG and have moderate AMR with pro-operative LVEF less than 15%. We divide them in two groups. 231 patients received isolated CABG, while 38 patients undergo CABG, combined with mitral valve repair. The middle follow duration was 38 months. Our primary endpoint was all-cause mortality. We use IPTW to reduce the confounding and baseline imbalance. That's the result. Here is the survival result. In the original cohort, CABG campaign with mitral repair showed better survival than isolated CABG, with a significant difference at p equal 0.049. Or after IPTW adjustment, the survival advantage balance even stronger with p equal 0.013. Overall, both analyses consistently show that adding MVR to CABG is associated with significantly low all-cause mortality. That's forest plot summaries that intimate predicts of all-cause mortality. Age, atrial fibrillation, stroke, and pro-operative LVDD were all associated with higher mortality risk. Importantly, concomitant mitral valve repair and beta blocker therapy at discharge, we are associated with reduced mortality. That's the echocardiographic result. Among 1,309 patients, 212 have available echocardiographic result. Follow-up median during 12 months, we can see the CABG combined MVR had significantly low prospective mitral regurgitation level and had a higher rate of improvement in mitral regurgitation. That's all. Thank you.
Thank you. Really appreciate it. We call for the next speaker for the next abstract. Yeah. Design iteration of a tissue engineered coronary conduit or the impact of modifiable cardiovascular risk. Thank you.
Thank you very much. Thank you to Prof. Taga and the whole faculty for allowing me to speak. I will stick to the 3 minutes of time. The title of the presentation is The Impact of Modifiable Risk Factors on Long-Term Survival from the University Hospital Southampton in the UK. So ultimately, modifiable risk factors such as diabetes, hypertension and BMI are known to affect survival. I mean, everyone knows this. And while their perioperative effects have been studied very well, the long-term post-operative influence remains less well defined in the literature. The aim of this study was essentially to determine the long-term survival impact over 20 years of these risk factors on CABG patients at our centre. So we looked at 14,462 patients who had CABG or grafts between 2000 and 2020. And we looked at all-cause mortality, assessing smoking, BMI, hypertension and diabetes. We fitted a Cox proportional hazards model, and we just did that for age and gender. And looking at our cohort, we had patients who were roughly around 70 years old. The majority of those were hypertensive, ex-smokers who were in the overweight category, and primarily were non-diabetic in our cohort, interestingly. We had a median follow-up of around 9 years. So looking at the crude mortality with the Kaplan-Meier curves, we can see there was, I'll just skip through these so you can get an understanding. This is hypertension and non-hypertension, which had a p-value of less than 0.001. Ex-smokers had significantly less lower survival at 25 years. The underweight category in BMI, you can see there had significantly worse survival. And lastly, diabetes. Insulin-dependent diabetes is the bottom line there, you can see in purple. So very quickly, when we fitted the Cox regression model, we did a basic adjustment for age and gender. We find that hypertension had a slightly increased hazard ratio over time, which was statistically significant. But really, the main takeaways, we can see that insulin-dependent diabetes was significant over the long term for these patients, as well as being underweight. Interestingly, and potentially in line with the literature, increased BMI didn't necessarily have any survival disadvantage. I think it's colloquially known as the obesity paradox. And we can see there that being a current smoker had a significantly worse outcome for you in the long term. So in conclusion, rather uncontroversially, diabetes, especially insulin-dependent diabetes, were the strongest modifiable predictors of reduced survival after CABG. BMI showed no major survival disadvantage except in the underweight category. And I think in keeping with some of the talks that have been given at this brilliant conference, with an increase in the use of medical therapy pre-op, especially in prehabilitation period, we should be able to optimize these patients, and we know that that will potentially improve their long-term outcome after CABG. Thank you very much.
Thank you so much. Dr. Taggart, one question very quickly.
Thank you. Very quick question. So thank you for a wonderful presentation, and thank you for coming to the meeting, and thank you for being here at 7 o'clock in the morning. But the one thing that slightly surprises me is that you had so many patients who were still hypertensive. Because if you're a patient in Oxford, your general practitioner makes sure everyone is on antihypertensive medication, statins and whatever else. So can you explain, please, why you had this, what I would say, a paradox of hypertension?
Sure. So the way we clarified or where we identified patients who were hypertensive were patients who, when they came to hospital, they had a blood pressure of above 140 systolic, and they were on treatment or not on treatment. So that did include those patients who you're speaking about. They may have been started on an antihypertensive by their general practitioner. But ultimately, when they came to hospital, they fit into that category that we'd essentially put them into that hyper. It is obviously more granular than that because patients who are hypertensive have levels of hypertension, and we put them into a binary category. So I fully appreciate your point.
Well, thank you. And may I, Mr. Chairman, just ask one very quick question, poll view here. In this audience of experienced cardiac surgeons, how many people are taking antihypertensive medication? If you're prepared to admit it, please put your hand up.
You took it too, Dr. Pascas. I know it. I saw it. Thank you.
Well,
Thank
if
you
you're
so much.
not on antihypertensive medication, you should be. And there is no level at which you can lower your cholesterol enough. So if you're not taking antihypertensive medication, if you're not taking statins, rethink.
Thank you. Thank you so much. The next one is a very interesting topic, the design iteration of a tissue-engineered coronary conduit with kink resistance and remodeling potential, preclinical insight. Please, Gabrielle.
Thank you. Good morning. My name is Abrielle Prunty, and I'll be discussing the design and preclinical results of a tissue-engineered coronary artery bypass graft. I am an employee of Vascudyne, and this is my only disclosure. So as many of you know, autologous vessels have some limitations. Some patients don't have enough suitable vessels. Vein grafts have seen to have some high failure rates in literature. And then additionally, autologous vessels require an additional surgical site, additional surgeon time, procedure time, and can impact the patient's postoperative pain and recovery. So an off-the-shelf option would address some of these limitations, and my team has created a tissue-engineered conduit for this purpose. It's made from fibroblasts and a fibrin gel and decellularized to make a collagen-based, allogenic, non-immunogenic graft for coronary artery bypasses. So we implanted these in 13 sheep out to 6 months and explanted to see recellularization and a clear lumen in most. However, we did see kinking in 4 out of the 13 sheep. And this was due to the dynamically moving environment of the outside of the heart, and this needed to be addressed before moving forward. So to address this, we made a nitinol laser cut external support structure that's available in one length to accommodate our 4 mm tissue engineered conduit, and 5 lengths, so then a surgeon can select the appropriate length for the appropriate coronary artery bypass target. It's soft and compressible and maintains its shape memory nitinol properties, so it's easy to load, position, and then maintains its structure over time. We implanted these in 9 sheep and saw 100% patency with this combined external support tissue engineered conduit. We brought 9 sheep out to 6 months, and 2 of them we went out to 18 months and discontinued anticoagulation at 6 months. At explant, you can see grossly that there's no severe immune reaction or scarring. There's connective tissue around the external support and tissue conduit, and the lumen is clear and shiny without thrombus along the length. Immunostaining also showed that there's presence of smooth muscle cells and endothelial cells, which is hopefully good indicators for long-term patency. So this graph shows some promise in the preclinical trial. We were able to overcome this biomechanical limitation of this dynamically moving environment of the outside of the heart. We showed patency out to 18 months with anticoagulation discontinued for 12 of those months, and we saw regeneration with smooth muscle cells and endothelial cells. We're hoping this shows durability over time and is also able to provide a conduit with more availability, just being off the shelf for all patients. We have a clinical trial currently going on in Europe. So if you have any questions, I'd be happy to discuss after this. Thank you.
This is fantastic, Gabriel. Very, very good. And Dr. Taggart, we are running very, very late. Gabriel, this is fantastic. How far you are from the first clinical data that can potentially go into commerce is one question, and then...
Yes, we have already implanted about 5 patients in Europe. And yep, so we are out to 1 month so far.
Fantastic.
And it looks great so far.
Thank you. Thank you so much. This is excellent.
Yes.
We will connect. Thank you.
Yes.
If I may ask one very brief question. So thank you for turning up on a Sunday morning at 7 o'clock to give what is a super presentation.
Thank you.
But one thing you haven't addressed, so if you look at the other evidence out there just now in terms of support for vein grafts, you haven't discussed what you've done with OCT or IVUS to try and judge, but you cannot judge it 1 year. You want to know what are 10-year outcomes. So where is your evidence that at 1 year you may be reducing intimal hyperplasia, which will eventually destroy your vein graft? But thank you for a great presentation.
Yes, thank you.
Thank you. Thank you so much. Okay. We will defer the conversation later. You can talk later. Thank you. Please.
Okay, so the next presenter is Dr. Do-San Kim. Please.
Dear colleagues, good morning, ladies and gentlemen. I am Dr. Kim from South Korea. Today, my talk is the de novo CABG showed better MACE outcome result than post-PCI CABG from my 20 years comparison. Nothing, I'm not mother tongue. Recent PCI versus CABG ratio in Korea 13 in last year. It is gradually increasing every year and by year. The post-PCI CABG is basically we appeared 3 different features. As you can see, failed PCI attempt, and in-stent restenosis, and remaining region progressive status. I want to illustrate between these 2 comparisons. During the period, among more than 1,000, Group 1 de novo is 73% and Group 2 is 27%. I used the inverse probability weighting test to reduce the confounding value. As you can see, we have the drug-eluting stent introduced in Korea since 2003, and this cohort includes the on and off pump CABG. And as you can see, before the valley, most of them are on pump. After the valley, the off pump is the main portion, and the post-PCI CABG is gradually increasing recently. So it is a very high risk patient, including concomitant cardiac, vascular, and other procedures, about 20%, and redo, and 9%. As you can see here, between the two groups, basically group 2 is older and higher risk group, as you can see. And my OP preference is like this. I use the pulsotomy and skeletonization. You can see the quadruple inside two bypass and others. Yeah. And perioperative, regarding the perioperative characteristics, as you can see, there is not significant between the two groups. Recently, the number of anastomosis is less in group 2, and the recovery is more improved than others. And post-morbidity and mortality, there are basically no difference except one, the sepsis. The OP mortality is quite high, but isolated is relatively acceptable. This is my result. All-cause mortality, cardiac deaths, and MACE, there is no difference between two groups. But the MACE is, as you can see here, from the 5 years later, it is diverse, and makes some difference, and they go to different pathways. So using the IPTW study, there is the same trend, as you can see. So when I used the subgroup analysis, failed PCI, the time interval 16 days, and instant restenosis 6 years, remaining disease 4 years, there is basically no difference between them. Yeah. So what happened in the standard corollary? I think the main driving force is the residual property of the stent itself. So it is needed to define why it is the basically different outcome result. Yeah. So in my conclusion, ladies and gentlemen, in spite of the high-risk population in post-PCI CABG or the severe coronary status, high PROM score, the de novo CABG showed the same outcome result. CABG showed the potential to solve any kind of PCI-related episodes, such as failed PCI attempt, instant restenosis, remained region progression, with a similar de novo CABG outcomes. PCI by time frequently, I think. However, in scope of lifetime cost effectiveness, de novo CABG should be considered. And the reason why after the 5 years later it is different distance, and maybe it is needed to define by the pathophysiologic study. Yeah. Thank you for your attention.
Thank you so much. Great presentation. Thank you for the bulk of data. We don't have time for further questions, but thank you so much. The next presentation is about early outcome of beta. Please, Mark Lutz.
Good morning. Thank you for the opportunity to present here today. My name is Mark Lutz. I'm a fourth-year medical student at Upstate Medical University in Syracuse. The data is from St. Joe's, which is a high-volume private practice in Syracuse. So just some quick background. I'll try to keep everything pretty brief, but beta has been historically avoided in obese and diabetic patients, largely out of the fear of increased surgical site infection risk and poor wound healing due to decreased blood flow to the area. But we also know that multi-arterial grafting has been demonstrated to show superior long-term outcomes. And the use of beta overwhelmingly remains underutilized in the US, less than 10% of CABG patients. So our objective overall was to evaluate these early outcomes and primarily surgical site infection risk in this patient population. So it was a retrospective review using institutional STS data from 2014 to 2024. All cases were isolated CABGs performed via median sternotomy. You can see the sample size there for both cohorts. The obese and diabetic cohort, that sub-analysis, obesity was defined as greater than BMI greater than 30. So as for our results in the total cohort, so all patients undergoing isolated CABG via median sternotomy, we saw a non-significant difference in surgical site infection between single arterial and beta. We also saw a decreased 30-day mortality in the beta group, as well as a decreased length of stay. Operative times were slightly longer. They ended up being numerically about 3 minutes longer, but it did reach statistical significance. In that obese and diabetic cohort, we noticed also no significant difference in surgical site infection. Again, we saw a decreased 30-day mortality in the beta group, as well as a decreased transfusion rate. All major postoperative complication rates were similar between groups. So overall, beta demonstrated a safe early postoperative profile. There was no difference in surgical site infection rate, even among a high-risk subcohort. And it should be considered more broadly, and I'll say in all populations.
Thank you so much. One question is skeletonized or pedicle? Skeletonized or
All,
pedicle?
sorry, all skeletonized, just about all
Thank you.
skeletonized in both groups. So that wasn't, no difference between groups.
Good. Thank you so much.
Thank you.
The next is the role of subcutaneous drainage in minimizing deep sternal wound infection by Salvatore Scianna.
Yes. Good morning, everyone. Thank you. This is my disclosure. As you know, beta grafting of pump is associated with a superior long-term outcome, but we pay a price in terms of higher risk sternal wound infection risk. The data come from a large analysis of multiple arterial versus single arterial CABG published by Sean and colleagues. The table presents adjusted odds ratio for two outcomes, but we focus only on mortality SSI. It's high, it's a double. Okay. Our rationale is evaluate with adding a subcutaneous drainage with a multimodal SSI prevention bundle in off-pump technique with beta. So it's idea, it's a thin idea, but works. We use in our practice only T-graft beta skeletonized. This is a prospective single-center cohort from January 2022 to December 2024. We enrolled 120 consecutive patients undergo off-pump with beta. There are two groups. Group A with 60 patients with received both mediastinal and subcutaneous drains. This group included 22 non-obese patients with sternal thickness superior 3 centimeters. Another group, Group B, without subcutaneous drainage. All patients we treated with the same multimodal SSI prevention bundle. Our primary outcome was SSI incidence, and we also assessed the length of stay in hospital. In our practice, we perform MRSI screening, used target prophylaxis with vancomycin and cefazolin IV. We operatively enforced the strict glycemic control, used vancomycin instead of bone wax, applied rigid external fixation. And so we optimize also OR flow, implement a UV terminal cleaning, reduced OR door traffics. Our result. Our overall SSI rate dropped from 4 to 2% in the group A with subcutaneous drainage. And in this group, length of stay was also impacted, is 6 days versus 8 days. In conclusion, subcutaneous drainage, when integrated into multimodal deep sternal wound infection prevention bundle, eliminate SSI in our practice. This is a simple, cost effectiveness, reproducible intervention that improve the safety of profile of beta grafting. We believe subcutaneous drainage should be considered as a standard component of enhanced recovery and SSI prevention protocol in center performing of pump with beta. Thank you.
Fantastic, Salvatore. Thank you. It was a great presentation. I invite the next moderators to come up about IRAS, and I tell Salvatore I use a subcutaneous drainage in all of my beta case.
Thank you very much.